Hello and welcome to Chapter 18, Assisting in Pediatrics. This is my favorite lecture of this class because I spent many years in pediatrics and I am excited to share with you. Learning objectives: define and spell and pronounce the terms listed in the vocabulary, describe childhood growth patterns, summarize the important features of the Denver 2 developmental screening test, discuss developmental patterns and therapeutic approaches for pediatric patients, identify 4 different growth and development theories, consider the implications of postpartum depression, explain common pediatric gastrointestinal disorders in addition to failure to thrive and obesity, describe disorders of the respiratory system in children, distinguish among pediatric infectious diseases, and recognize the etiologic factors and signs and symptoms of the 2 primary pediatric inherited disorders. So, normal growth and development. The factors that affect growth and development are genetics, nutrition, environmental factors, presence of disease, and caregiver interactions all affect the growth and development. So growth refers to measurable changes such as weight and height, and development considers qualitative maturation in motor, mental, social, and language skills. Pediatricians check for indications of irregularities in growth and development. So some growth patterns that we want to look at birth weight. The birth weight triples by age 1 and the length increases by 50% regularly. By age 3, the child starts to slim down. From 3 to 6, weight increases, and 3 to 5 pounds per year is a typical weight increase, and the height increases about 1.5 to 2.5 inches per year. There's continued growth, especially in the legs, until about the age of 12, and then a growth spurt usually occurs before puberty begins. So by age 4, the child usually has doubled their birth length. And the body mass index, the BMI, can be calculated by dividing the child's weight in kilograms by the height in meters squared. Let's look at the Denver 2 developmental screening test. So each child develops individually and attains developmental plateaus differently. So we have a standardized tool, and this is to screen for developmental delays, to investigate concerns about an infant's development, to monitor high-risk children for potential problems, and this test should be given at ages 3 to 4 months, 10 months, and 3 years. Only those trained in the procedure and in the interpretation of the results should give this test. This focuses on 4 key developmental areas: gross motor skills, language, fine motor skills, and personal skills. The results are then analyzed and determined to be normal or suspect, or the child is diagnosed as untestable. You can look at figures 8.1 and 8.2 in your book for more information on this. So some therapeutic approaches for infants. Crying is normal, so we want to help by distracting without overstimulating. So if we can get the baby and even the infant all the way through young children, if we can distract them and not overstimulate them, we can usually calm it more easily. The baby should stay close to the caregiver. Involve the parent as much as possible in the whole visit and what you're doing and the explanations. Place a familiar object near the baby. If the parent brings something that the child the infant is familiar with, keep that next to the baby. So 8 months old is usually when we see stranger anxiety start to develop. And we only want to restrain when it's necessary for safety. So you will notice on your resource videos this week, there was a student video that was kind of cute of the right and the wrong ways to deal with children, and this also qualifies for infants. We want to encourage the caregiver to cuddle and hug during the procedure, and some other things that can work if we're not overstimulating, something that has pretty colors. And for example, I used to have a little rattle pen that made a nice soothing noise, and it could kind of distract, usually, especially if the baby was starting to get upset or crying, because it interests the baby. So thinking about some things you might be able to have with you on a daily basis to help with this. Unpleasant procedures are associated with other objects, so do not use play areas for treatment, and do not use a favorite toy or object during the procedure. We'll make sure that we offer it to the infant afterwards for comfort if they have something that's, their favorite. General patterns of child development occur rapidly during the first year of life as the infant progresses from reflex activities to learning to manipulate simple objects. And especially in infants, this will be your biggest challenge because you will be giving injections to the infants, and the babies they don't really understand what is going on at the time, and a lot of times the parents have a lot of anxiety and the infant picks up on that. So it's important to make both the parent and the infant comfortable. So let's talk about toddlers and preschoolers now. We want to ignore tantrums and negative behavior. We want to praise the child. We want to get our unpleasant procedures done quickly. So we want to make sure we're really good at them and that we can get them done quickly, and we don't torture the toddler or preschooler by taking too long. We want to allow the child to keep on as much as clothing as possible because they, are starting to be more aware of privacy, and also it keeps them warm and comfortable. Use familiar words with the toddler or preschooler so that they are understanding what's going on. Explain the procedure as the child would experience it, and allow him or her to handle the equipment. So again, in one of the resource videos you saw this week, we have the stethoscope, and we talk to the child in a way that they understand, and we let them hold the stethoscope. You can even have just a really inexpensive one that they can hold and touch and put in their ears so that they can handle and understand. And this will help them to cooperate with you and to feel more comfortable. Do not demonstrate on the child's favorite doll or stuffed animal. Typically, this is does not go well, because if the child has their favorite doll or stuffed animal, then they're very protective as well. Now, sometimes if the child asks you to do this, then of course that would be a different situation. You want to make sure that you explain the procedures to the parents away from the child if possible, so that you don't cause any additional anxiety. If this isn't possible, again, trying to explain in a way that the child will understand, and not making it something that feels uncomfortable, like you're telling their parents a secret or that they're not involved. By age 3, the child is showing that increased autonomy, so they are becoming more aware and really wanting to demonstrate that. So it's important, again, to respect that in the toddler preschoolers. Now, during the preschool stage, the child becomes increasingly independent and initiates activities, so we want to utilize this to our benefit as well. So for school-age children, We want to give them as many choices as possible. So you'll get used to this if you're working in pediatrics, as to the areas that you can give them choices. This helps them to feel that they're participating. And a parent or caregiver should still be present with a school-age child. Again, we want to remove minimal clothing. We definitely want to explain the procedure in concrete terms so that they understand it. And then we want to give the child time to ask questions, not just the parent. So we want to give them a little bit of time to kind of process it and be able to ask their own questions. And we at school age start to really address the conversation directly to the child. Again, we have the parent involved, but at school age, we're trying to help them feel their independence and understanding of what we're doing and build that trust with them, because a lot of these patients have been with you since infants, and you really do have an opportunity to build relationship and trust throughout that time. School-age children have perfected their fine motor skills, so they can paint and draw and play an instrument, and they're very capable of doing those things. So that's just a little developmental note that I wanted you to be aware of. So adolescents. Adolescents become very self-conscious, and as we know, in adolescence, we're very influenced by our peers. So privacy is key, and we want to respect that. We want to address how the procedure might affect appearance. If there's anything that they're doing that they might have a scar or different things, we want to make sure that they understand and ask those questions too, because that's going to be in their mind. Do not be judgmental when listening. Encourage them to verbalize their concerns or fears. And encourage teens to see the physician without a parent present at this point, so that you are able to build that trust and talk and get all of the information. This doesn't always happen, and of course it is up to the teen and the parent to make that decision, but we do get a lot more information if the teen and the parent are comfortable, and we can have the teen see the physician without the parent. Teenagers want to be treated as adults, and they really want to know what is being done and why, just like we do as an adult. So it's important that we cover that with them. And in an attempt to establish an adult identity, the teenager proceeds by trial and error. So they don't really know what that looks like yet, and they are trying things out and doing trial and error. And so we want to, again, build trust and help them and model how to be able to get through an appointment and a physician visit, without having to depend and rely on the parents necessarily, depending on the situation, of course. So, developmental theories. There are several out there. We're going to look at Sigmund Freud, who believed that motivating stimulus for human behavior is the libido, and he was the first therapist to identify the 5 developmental stages. Erik Erikson was a psychosocial approach. He took a psychosocial approach, and it was theory based on 8 stages of development. Each stage focused on a developmental crisis. So the 4 major components of the mind, according to Freud, are the unconscious mind, the id, the ego, and the superego. And you can look at table 18.1 for a summary of these growth and development theories. So Jean Piaget focuses on intellectual growth and the 4 stages of cognitive development. And Lawrence Kohlberg focuses on moral reasoning. So the 4 stages of cognitive development, according to Piaget, is sensomotor stages, pre-operational stage, concrete operational stage, and formal operational stage. Again, you can look at table 18.1 for a summary. take a look and discuss postpartum depression because this occurs an estimated 10 to 25% of women struggle with major depression